session, we will understand the definition and subcategories of preterm infants and related terms, such as low birth weight, very low birth weight, extremely low birth weight infants. Besides, this session will cover aspects related to the resuscitation of preterm infants who require assistance to breathe. We will also discuss the importance of kangaroo mother care. Approximately 15 million infants are born preterm annually worldwide. According to the World Health Organization, infants are termed preterm when they are born before 37 weeks of gestation. There are further subcategories of preterm birth based on gestational age. Infants are termed extremely preterm when they are born before completion of 28 weeks of pregnancy. Similarly, very preterm infants are born between 28 and 32 weeks of pregnancy, whereas moderate to late preterm infants are those born between 32 and 37 weeks of pregnancy. Infants are categorized as low birth weight if their weight at birth is less than 2,500 grams or 5.5 pounds. An estimated 15% to 20% of all global births result in low birth weight infants, which means more than 20 million low birth weight infants. Low birth weight infants can be further categorized into very low birth weight and extremely low birth weight infants. Very low birth weight infants weigh less than 1,500 grams or 3.3 pounds at birth. Extremely low birth weight infants weigh less than 1,000 grams or 2.2 pounds at birth. In the first module, we have covered a systematic approach to neonatal resuscitation recommended by the American Heart Association. Here is a summary of the steps involved in neonatal resuscitation. Neonatal resuscitation can be divided into 5 components: initial assessment, airway, breathing, circulation, and drug administration. Initial assessment involves determining if the newborn can remain with the mother or should be moved to a radiant warmer for further evaluation. This is done by rapidly assessing if it is a full-term gestation, if the infant is crying or breathing, and if the muscle tone is good. If the answer to any one of these questions is a no, then additional interventions may be required. The second step in neonatal resuscitation is airway management. Steps are taken to establish an open airway and support spontaneous respiration. If the infant fails to breathe spontaneous after clearing the airway, then the newborn requires ventilation to breathe, which is the third step in neonatal resuscitation. Positive pressure ventilation is provided to assist breathing for infants with apnea or bradycardia. Other interventions, such as continuous positive airway pressure or oxygen, may be required if the infant has labored breathing or low oxygen saturation. When severe bradycardia persists despite assisted ventilation, then circulation is supported by performing chest compressions coordinated with positive pressure ventilation. This is the fourth step, circulation. The fifth and final step is drug administration. That is, if severe bradycardia persists despite assisted ventilation and coordinated compressions, the drug epinephrine is administered along with positive pressure ventilation and chest compressions. In the case of preterm newborns, it is more likely that they would have difficulty in transitioning to an extrauterine environment, thereby requiring additional help and interventions. However, since preterm infants are more vulnerable to injury from resuscitation procedures, it is crucial to strike the correct balance between initiating resuscitation without delay and avoiding unnecessarily invasive procedures. Proper management during the first minutes after birth may decrease the risk of both short and long-term complications. Let us begin by understanding why preterm infants have a higher risk of complications. Preterm newborns are at an increased risk of rapid heat loss due to thin skin, decreased subcutaneous fat, and large surface area compared to their body mass. Their ability to breathe spontaneously is poor, as they have weak chest muscles and less flexible ribs. Preterm newborns have immature lungs, making it more difficult to ventilate and increasing the risk of injury from positive pressure ventilation. Moreover, immature tissues are more easily damaged by excessive oxygen. They also have small blood volumes and therefore risk hypovolemia when there is blood loss. The brain of preterm newborns is also prone to bleeding and damage because the blood vessels are immature and cannot handle quick changes in blood flow. With these complications in mind, let us look at what additional resources are required to resuscitate a preterm newborn. It is important to ensure the presence of sufficient skilled personnel to perform complex resuscitation and document events as they occur. Additional supplies for maintaining the temperature, such as a polyethylene plastic wrap or bag, thermal mattress, a hat, temperature sensor, and a cover for a radiant warmer are essential. An oxygen blender, compressed air source, pulse oximeter, appropriate sized oximeter sensor are required. An electronic cardiac monitor with 3 chest leads or limb leads provides a rapid and reliable method of continuously displaying the infant's heart rate if pulse oximeter has difficulty acquiring a stable signal. A resuscitation device capable of providing positive end expiratory pressure and continuous positive airway pressure is preferred. A resuscitation mask that is preterm size 0 laryngoscope blade, and a preterm-sized endotracheal tube needs to be kept ready. A surfactant can be considered if the infant is expected to be less than 30 weeks gestation. Lastly, a pre-warmed transport incubator is required if the infant is moved after the initial stabilization. Now that we have understood the additional resources required, let us discuss the additional steps or care required in resuscitating a preterm newborn. The first and foremost necessity is keeping the preterm newborn warm. Preterm newborns are more susceptible to heat loss. While drying with warm towels, skin-to-skin contact, and early breastfeeding are sufficient to keep term infants warm, additional measures are required to keep preterms warm. These include increasing the room temperature to approximately 23 to 25 degrees Celsius, preheating a radiant warmer before the time of birth, using a hat or cap to cover the infant's head, wrapping the infant in 1 or 2 sheets of polyethylene plastic wrap or bag, and using a thermal mattress if less than 32 weeks gestation. Overheating must be avoided by using a temperature sensor. The next stage of resuscitation that requires special attention for preterm newborns is during ventilation. Immediately after birth, if the infant is breathing spontaneously with a heart rate of at least 100 beats per minute, but has labored respirations or low oxygen saturation, consider using continuous positive airway pressure instead of intubating. While the criteria for initiating positive pressure ventilation is same as with term infants, keep in mind that if positive pressure ventilation is required, the lowest inflation pressure necessary to achieve an adequate heart rate response should be used. An initial inflation pressure of 20 to 25 centimeters of water is adequate for most preterm newborns. Also, when positive pressure ventilation is required, it is preferable to use a device that can provide positive end expiratory pressure, or PEEP. Using this helps the infant's lungs to remain inflated between positive pressure breaths. Next, if the infant requires intubation and mechanical ventilation for respiratory distress or is extremely premature, then consider administering surfactant. This is because preterm infants have immature lungs that lack surfactant, a compound that prevents the alveoli from collapsing at the end of each exhalation. It is best to follow your local or hospital guidelines regarding the criteria for the administration of prophylactic surfactant. The last aspect of resuscitation that requires extra care for preterms is the use of oxygen. The immature tissues of preterms' lungs are easily damaged by excessive oxygen. However, many preterm newborns will require supplemental oxygen to achieve a gradual increase in oxygen saturation. In regard to the use of supplemental oxygen, the latest recommendations suggest that in late preterm newborns receiving respiratory support at birth, the initial use of 21% oxygen is reasonable. 100% oxygen should not be used to initiate resuscitation because it is associated with excess mortality. In preterm newborns receiving respiratory support at birth, it may be reasonable to begin with 21% to 30% oxygen, and the subsequent oxygen titration should be based on oxygen saturation targets. Apart from the extra steps during resuscitation, one must also take precautions to decrease the risk of neurologic injury in preterm newborns, because the fragile networks of capillaries in their brain are prone to rupturing and bleeding. Hence, it is crucial to handle the preterm gently. Positioning the infant's legs higher than the head, called the Trent-Ellenberg position, must be avoided. During positive pressure ventilation or continuous positive airway pressure, high airway pressures are avoided. An oximeter and blood gases should be used to monitor and adjust ventilation and oxygen concentration. Finally, rapid intravenous fluid infusions and hypertonic solutions should be avoided. After the preterm infant is resuscitated and stabilized, it is vital to monitor and control the preterm newborn's blood glucose, temperature, oxygen, and ventilation. Look out for the occurrence of apnea and/or bradycardia and intervene promptly if needed. In the last section of this video, we will discover the importance of kangaroo mother care for preterm newborns. The World Health Organization defines kangaroo mother care as the care of preterm infants carried skin to skin with the mother. Its key features include early, continuous, and prolonged skin-to-skin contact between the mother and the infant, and exclusive breastfeeding or feeding with breast milk. According to the World Health Organization, kangaroo mother care is recommended for the routine care of newborns weighing 2,000 grams or less at birth, and should be initiated in healthcare facilities as soon as newborns are clinically stable. If continuous kangaroo mother care is not possible, intermittent kangaroo mother care, rather than the conventional care, is recommended for newborns weighing 2,000 grams or less at birth. Kangaroo mother care was started as a low-cost alternative to incubator care in areas with limited resources. However, over time, clinicians and researchers have found that it has several psychologic and behavioral benefits for both the preterm infant and the mother. Kangaroo care can help preterm newborns maintain healthy body temperature and better cardiorespiratory stability. In fact, when compared with standard care such as incubator, radiant warmer, or open crib, kangaroo care has shown better outcomes for homeostasis. During the hospitalization, kangaroo care may help to reduce the likelihood of infection, severe illness, and death of preterms. The sleep patterns of infants are said to be better in the presence of kangaroo care, with an increase in quiet sleep, longer sleep cycles, as well as more regularity in respiration. It is also found to diminish pain felt by newborns during procedures. Studies show that kangaroo care also supports brain development. Some research suggests that continuous kangaroo care is also associated with better growth, including an increase in weight gain, length, and head circumference. Kangaroo care is said to positively influence maternal milk volume, promote breastfeeding exclusivity, and breastfeeding duration among preterm infants. It improves the relationship and attachment between the mother and newborn. Let us now understand how kangaroo mother care should be practiced in the hospital. The mother should be advised to hold her newborn in an upright position, swaddled on the chest, with skin-to-skin contact. It is preferred if nothing is present between the mother's chest and the infant's skin, other than a diaper. To sum up, we have learned about the definition and categories of preterm infants, the meaning of low birth weight, very low birth weight, and extremely low birth weight, the differences in resuscitating preterm newborns who require assistance to breathe, and finally the importance of kangaroo mother care for preterm infants.